yes, we're developing, but there are a lot of things that we don't have yet. And there are a lot of children that we should be able to save that we don't save. Then on the angle of preventive health, again, that is a lot of factors are in interplay. Okay, when you don't have adequate housing, you don't have good roads, you don't have electricity, you don't have potable water, all these things culminate into, poor preventive practices. And so we still have vaccine preventable diseases, we still have diseases that, we should be able to prevent in our country, still at the top list of the diseases that we have that kill our children in Nigeria. And these are unfortunate situations.
Amazingly, you've been able to cover the challenges and even some of the issues you are facing in this department. But I'd like to ask, you said it's that there are a lot of diseases affecting children. What is the most commonest that affects kids?
Well, commonly, even just like people tend to underrate, one of the commonest remains the malaria, the age-long malaria, which kills close to 500,000 children annually, globally.
Between the age of
0 to 5.
Wow.
And then Nigeria contributes a huge percentage of these numbers. We contribute close to 30% of this figure.
How so?
And that is worrisome. Okay, and so you talk about other diseases, cholera, pneumonia, okay, diarrhea diseases, okay, and then of course HIV, tuberculosis. These are common diseases that kill our children. And a good number of times, preventive measures are there that can reduce their numbers, okay, and then there are treatment modalities that are available and should be affordable so that we can reduce the death rates.
You said 30% are from...
More than 30% of the deaths recorded from malaria are attributed
to Nigeria.
To Nigeria, yes.
Wow.
So what role, you talked about vaccination before, what role do you think vaccination play in, improving health, and how effective are Nigeria's immunization programs, in terms of playing that role right now?
Okay, thank you very much. That's a very good one. Well, vaccines. In fact, vaccines are one of the foremost and the most impactful, development that has happened in the world of health. Okay, since the advent of vaccines in the world has been able to reduce death, morbidity, and mortality from vaccine-related diseases. You can go back years back when it was the era of smallpox, okay, and then all the other vaccine-preventable diseases that vaccines have helped us to drastically reduce their numbers in terms of the numbers that come down with them, and then the morbidity and mortality that occur, even for those that eventually come down with them. So vaccine is the single most important intervention that has happened in health worldwide. And so when we come down to vaccines generally, the Nigerian schedule, which is the National Program on Immunization, yes, a lot has happened, okay, a lot of vaccines are there, but there are also a lot of criticisms that have come up. Okay, one is the need for booster doses, because we've realized that some children will have the available doses within the schedule, the National Program Immunization schedule, and they still come down with the disease. Okay, that was what led to the second dose of measles. Usually first dose of measles is at 9 months.
Yes.
So second dose was introduced in 2018 between 15 to 23 months. And that was because they realized that a good number of children, even after having received the first dose of measles at 9 months, they still come down with measles. Even though it may be milder, but they still come down with measles later on. And so the program introduced the second dose, okay, so that they can improve the herd immunity to at least 85%. So we actually need booster doses of some other vaccines, okay, that can help us to increase the level of protection that our Nigerian schedule provides.
Could you mention those vaccines? Really?
Okay, so now we're talking about the Penta, okay? The Penta has 5 vaccines in it, okay? Now, those illnesses that those vaccines are supposed to protect, okay, you still find children that may come down with them because the number of doses we have within our schedule still give room for some children to come down with it, okay? So when we have more booster doses, for each booster dose you give, you increase the percentage protection that a vaccine gives. Also, associations like Pediatric Association of Nigeria, PAN, had actually some years back came up with what they propose should be a schedule. And that schedule they expect will incorporate more booster doses of most of these vaccines and will stretch up to much later on in life, 15 years or more, so that we're able to take proper protection of these children up to later, childhood. Okay. Now we realize that a good number of children, rather what we have in our MPI, before the second dose of measles was introduced, there was virtually nothing we give outside the first year of life. If a child receives the 9 months vaccine and goes home, nothing else. And we know what happens when they come to receive their vaccines, what we call the well child clinic, where they receive their vaccines. The nurse or the health worker there will also check their weight, check their height, ask more questions about the child, identify issues on that child, and if where necessary, make appropriate referral to a specialist who can now treat that child. But a situation where we don't have more of such exposures, opportunities for that child to come, receive booster doses, which will offer high percentage protection, and also offer the health work opportunity to identify issues on that child as the child grows. Then it robs us of that opportunity to identify health issues early, health issues that the mother may consider little or may not even know the importance. So at that point, such children are missed. It's only when they now come down with full-blown illness or they are at the point of death that the mother may realize, oh, there's a problem. At that point, things that could have been curbed earlier are lost. Okay, so with what PAN is proposing, if it's implemented, okay, we'll have better protection, we'll have better, we'll derive better benefits or higher benefits from our program. But you see the challenge is, we're still dependent on donors for our vaccines. Okay, some other countries have moved, they actually support their vaccines, okay? Some even try to have facilities that can produce some of these vaccines within, okay, and some medications within their countries. But it's not the same here. So we're dependent heavily on donors, and some vaccines, okay, that some other countries have adjusted, we're still saying, oh, we're receiving donor funds and we're still managing, and it shouldn't really be. I don't think our country is that poor. Okay, and when a group of specialists like PAN, has proposed something from their wealth of knowledge and all that, it should actually be given some priority. It should be looked at and considered. So yes, a lot of vaccines have come in, okay, like what we have for rotavirus came in, second dose of measles has come in. Okay, there's a lot of talk about HPV, human papilloma virus vaccine, okay, which we know 9 to 14 years majorly, okay, but I know that we can do a lot better than where we are.
Okay, so I want to take you back to, we'll still come back to vaccine, but I want to take you back to the challenges. You've mentioned a lot of challenges, and you've, of course, I want to believe that you reached out to the federal government for help, the Ministry of Health and all of that. But how has the government responded to these emergencies?
Well, government, just like in every other sector in our country, the response, you can look at it from different angles, because one is not what is said, it's not by statements, it's about action. Actions. So when you look at our budget for health as a country and you compare that with what it should be, you realize that we are far below where it should be. We're still talking about single-digit percentage for health budget. And that tells us where we place health as a nation. Okay, and then when we look at our health insurance coverage, that's another area where we encourage, even if federal government hasn't been very, hasn't come out fully the way they should, states should take it up. I remember some years back, we, under PEPFAR, under what do they call it? The program we had in Enugu, Part 2. Okay. Part 2 came up with PPP arrangements. Okay. And for vaccines, they had a lot of views, as well as other areas of health. They had views about what could be considered so that health can be made available to people. People can access health. Okay, but some of these things come up, good ideas, but they don't see the light of the day. Okay, so when it comes to what is budgeted for health, okay, health coverage, universal health coverage, we talked about community-based health insurance. Okay, we also have state health insurance scheme. How effective is it? What is the percentage coverage? Can an ordinary businessman in the market access healthcare in our health institutions in the state using health insurance? So it should, if we made it mandatory on the health insurance document, it is compulsory. Now the next thing is implementation. Okay, every single individual in the state or in the country above 18 years should be contributors to the health insurance in one way or the other. Okay, and every child, every person in the country or in the state should be able to access health insurance. And you know the benefit of health insurance. It borders on pooled funds, where there is a pooled fund to support those that can, even you that is contributing and you are so big, you want to go abroad, there are certain things that can happen to you that may not even give you opportunity to buy that ticket and travel abroad. There are things that can, within 24, 48 hours. Malaria, for example, can kill a child within 24 hours. So why wouldn't you have an effective health insurance coverage that offers the benefits to all and sundry? It can contribute dependent on what you generate. Even a vegetable seller in the market can contribute to the health insurance package. It could be 20 naira, it could be 15 naira. But all you know is that there are basic illnesses that should be covered. And when we have that pool of fund and it is big enough, we can actually expand the range of what we have currently. Currently, we have some illnesses that may still look quite basic, but it's not covered by the health insurance. You have to pay out of pocket. Okay, and then instances where you go to and you can't even have any meaningful drug. They'll be giving you drugs that are the very cheap ones that they are even not so certain. And they'll tell you that's what the coverage can, that's what the health insurance can cover.
Yeah.
So in other places where it's working well, you can do major surgeries with your health insurance cover. You can access any drug you want with your health insurance cover. And that is what we should be aiming towards. So everybody, having made it mandatory on paper, it should actually be compulsory in real action.
So how are pediatricians in Nigeria, dealing with the high rate of infectious disease? Because yesterday, from one of our newspapers, we heard that, we got that there's an increase in the kwashiorkor in children right now. But these are the things that we rarely see, we rarely hear about. But right now, it's been in the increase. And you can attribute it to malnutrition, you can attribute it back and trace it back to high rates of or cost of living in Nigeria. So how are the pediatricians dealing with these high rates of infections, different infections among children?
Yes, thank you very much. Well, I must tell you that I work in Children Emergency Room in Park Lane. I'm the unit head before I became the head of department. And I realized that, in fact, since middle of last year or thereabout, there has been an upsurge in the number of malnourished children we see in Children Emergency Room. In fact, in Children Emergency Room, let me not start quoting, let me use what we see on ground, not just what is on paper, statistics here and there. We realize that close to half of every patient that comes into Children Emergency Room have one form of malnutrition or the other. Be it moderate acute malnutrition or severe acute malnutrition or chronic malnutrition or what we call hidden hunger, micronutrient deficiencies. And we know that this malnutrition, what do they cause? They make a child more susceptible to diseases. And when a child is malnourished and has an additional illness, the likelihood of a bad outcome from that illness is increased several folds by the presence of malnutrition in that child. And so when you have a child that is malnourished and that child comes in ill, there are several factors. You also look at the nutritional status of the parents, look at their socioeconomic background, okay? What job are they doing? What is their economic indices around them? What is the educational background? Okay, these are the things that perpetuate poverty. And then harsh economic and political conditions we have within and outside the country, particularly within the country. And so malnutrition is a very big problem that has changed the landscape, the outcome of our patients in different aspects, both those in the emergency room, those in the wards, and what have you. Now, the Pediatric Association of Nigeria, PAN, has an advisory role. Okay, as an association, just like every other association that advocates for the rights of children, okay, they advocate they try to interact, they try to come in with views, they come up with their statistics, their data, and they try to advocate for the rights of children. But one thing is to advocate. Another thing is that your advocacy may not see the light of the day. It may not bring about a change. But you don't stop advocating, and that's what PAN does largely. So PAN there is a pool of specialists handling child health, children, and they come up with suggestions, they come up with advocacies, they come up with advisories to government. But whether they utilize that or not, it's something that we all can answer. In most cases, they are not really utilized, and that is where the issue is. Okay, so we now look at what do we do? A good number of pediatricians go to hospital with money in their pocket and they go home empty. I can tell you that as a pediatrician, children emergency where I work. If you go to certain hospital with money in your pocket, you know the kind of person you are, how hard your heart is, that you go with money and go back with that money or part of it. And you got to a level where people now go, pediatricians now go seeking for help from NGOs, individuals, philanthropists, so to see how they can raise money to support those. A patient will come to the hospital without a kobo. You cannot buy a card for you to even write. When you finish writing, after you've bought card for the person cannot provide the basics. So that's how bad it is. Now you look at what the child is eating, you realize that that is not compatible with life. As we may look at it, it may sound funny, but we heard about this. We had the story of a woman that gave her children poultry feed.
Yes.
Probably that may be someone that works in a poultry, because even poultry feed is not cheap. That may be a woman that works in a poultry and of course took some and went home and fed the children with it. That tells you how bad it is. So malnutrition has increased. The figures we had in our country, in our state, as at 2017-18 is different from what we have now. It's approaching close to 40. People talk about 17-21% some 3-4 years ago, but it's far beyond that as we speak. And that is how bad it is.
Okay, so let's talk about vaccine now. Just a few weeks ago, we heard that we've been given from World Health Organization, about 800,000 plus vaccine for malaria for 0 to 5. And you said that's the most, that's the age range for which the mortality rate is high for malaria deaths. Now, I want to get your perspective on that first before I move on with my question.
Okay, yes, that's a very good one. 846,000 units, and then additional 154,000 should have come in yesterday, according to the Ministry of Health. I'm here to confirm if you arrived. So we're expecting a 1 million vials or units. Okay, so the malaria vaccine has been something that the struggle to get a malaria vaccine has been on for over 30 years. Okay, and part of the reason why there was a challenge coming up to the vaccine is because of the multi-stage nature of the parasite. So it was difficult for you to pin it down easily. Okay, but we now have two different vaccines, what we call the RTS-S and then the R21. Okay, the RTS-S is commonly known as the mosquirix. Okay, and all these target these sporozoites. The sporozoites are a particular stage of the parasite, which is one of the initial infective stages.
That organization
so as they come out to begin to cause their processes, they are destroyed by what the vaccine has done. So the vaccine, when it's given, what does it do? It stimulates the body to produce immune cells against those sporozoites. Okay, so when the mosquito bites the person and introduces the parasites, as they go through their stages and then come out in the bloodstream to start the clinical signs and symptoms, the antibodies that are produced by the body in response to that vaccine that was given will now clear those sporozoites. So it's a welcome development. Countries like Kenya and Malawi, they started theirs earlier, I think last year or so, and they had very wonderful outcome from it. They had up to 75% decline in cases of severe malaria. They had over 13 to 30% decrease in the percentage of overall mortality in children less than 5 years in these countries. So Nigeria's case will not be different. Nigeria, based on our population, which is actually supposed to be a blessing, is also now showing in our figures in most of these illnesses. So with your population, and we have a high population of young people, including the under fives. So anything going wrong in any of these populations will reflect in high numbers. That is what Nigeria has always suffered. And that is why we always should benefit maximally from interventions that are there. So the malaria vaccine is a very welcome development. It's a very good thing. In fact, I've not heard of any complications or any negative outcomes from malaria vaccine. And children that have had that, countries that have introduced that, have done very well. What we should not be talking about is that the KB and Bayelsa they are talking about, they're introducing it to, of course, we know they looked at their high prevalence and all that, and say let them start. And then they looked at their pool, their population, target population, it was close to that 1 million. So they said, okay, let's use that and see what the effect it will have on those two states. So with about 18 million to 20 million vaccines currently, and the way things are going, the world should be looking at about 80 to 100 million vaccines in the next couple of years, between now and 2030. Okay, because the vaccine will actually do a lot in the malarial struggle. But the vaccine alone, the vaccine is not alone in the struggle. Other things have to come in.
Yeah.
Okay?
So
When you say other things, what other things?
So other things will be one, our old and reliable net use. Nets.
okay, that's
Oh,
the
yeah,
mosquito
mosquito
net
net.
itself.
Yes,
Okay.
long-lasting insecticide-treated nets. It must come and it must be available, and people must be encouraged to use it. And part of the problems we have with that is that you see parents that don't like to use nets. And when you don't use net as a parent, you don't encourage your children to use their nets.
But how about that argument that people say is it causes rashes and itches on their body?
Well, the net will not cause rash. For those that have allergies, if you have allergy to the insecticide impregnated in the net, yes, you can have can react to it, the skin rash, you can have cough, catarrh,
Yeah, readiness
and
of
all
eyes,
that,
yes.
allergic symptoms. Now, what I would suggest for those that have allergy, one is that if you air the net, okay, not outside, not in the sun, but within,
Oh, so the proper way is not in the sun.
yes, no, it's not supposed to be the sun. You're supposed to air it, but not under the sun.
Okay.
When you air it, and then you start using that, it helps reduces that likelihood of having those allergies. Secondly, but if you still have allergies to them, then it's better you use plain nets, not the one with insecticide treated,
Okay.
because if you don't use nets at all, you're fully giving mosquitoes, full access to yourself. Okay, so other things, of course, will be our indoor spraying, residual indoor spraying. Okay, vector control generally. That's an area, because it's a very expensive thing. Vector control is an area we're not doing well as a country. Okay, we're still relying more on anti-malarial, providing artesunates for severe malaria, sharing mosquito nets, and so on and so forth. But even that mosquito net use, we need to create more awareness on it. We need to make it more available. A couple of instances, people have these nets, but they don't distribute them well enough, or it goes into the wrong hands, right down to the grassroots, people that need them. Okay, so actually checking the spread or the distribution of these facilities is also very important. Availing hospitals, PHCs, general hospitals, teaching hospitals with available medicines. Almost all the states have distributed anti-malarials, injectables, and so on, and orals. They should get those anti-malarial available.
Just in 1 minute, because of time, before we'll let you go. As a consultant pediatrician, what measures do you think should be in place to reduce infant mortality rates in Nigeria?
Well, this is another topic altogether. But
Just a
well,
few.
we'll try to scratch it as much as possible. Prevention, they say, remains the most important thing. Because we are not so advanced, even in the advanced world where they have all the facilities for intensive care and all that, prevention still remains the bedrock. Okay, so when you talk about those preventive measures, you realize that it's multi-sectorial. Okay, when a pregnant woman cannot access good roads, pregnant woman goes to a PHC or general hospital and there's nobody there, it's closed. When there's no drinking water, potable water, don't have electricity to even preserve medications and vaccines, there are a lot of issues. So it's a multi-sectorial issue. Now look at now, let me narrow it down to the health sector. Okay, we looked at the PACs and we see that their functionality is in question. They lack manpower, they lack basic equipment and tools, they lack access. Sometimes you go to a PAC, they tell you that the queue there delivered, and so the hospital is closed. So people have to travel from a village to a teaching hospital to access healthcare. So we must look at how to have health workers that can run contiguous health facilities. If you have 3 PACs that are in close proximity, you can situate a building for a doctor, equip a building, even if it's a bungalow, equip it, provide light there, let him be able to live there with his family, willing persons, pay him as per state level. Let him be able to run those contiguous primary healthcare facilities. He will train the manpower there because they will learn from him. He will be available to take deliveries. Okay, and mortality, because these deaths you are talking about, they are not mainly in our towns. They are largely in our rural environments. The newborns, the same thing. So when we look at deliveries, you look at how deliveries are conducted. The skills are not there. So we need to bring skilled manpower closer to the rural environment. And that is one key thing that we need to do. It's not just to equip the facility and let it be devoid of skills. It must be accessible. The facilities must be there. The manpower that can drive those facilities have to be there. The confidence of the people on those facilities have to be re-established. Because of what happens at those levels, people don't go there. So every single malaria, respiratory tract infection, cough and catarrh, they will go to teaching hospital. And then that is now distorting the health pyramid, which should be bottom heavy and top light. But we now have an opposite. You have everybody going to teaching hospital to go and access treatment for malaria because the primary healthcare facilities are not functional.
Thank you so much.
So it's a very big topic which I think we may consider.
Of course. We'll have a segment entirely for health that would handle this. So thank you very much for coming in, Dr. Obinna, senior lecturer and consultant pediatrician. Thank you very much for this insight.
Thank you for your time this morning.
Thank you.
Yeah. You can find this interview on our social media platform. You can find it on our website at www.signaturetv.org and on our YouTube channel. Of course, you can find the excerpts as well on Instagram, Facebook, and Twitter, and TikTok as well. We'll see you after this. We'll have another conversation lined up for you. You want to stay tuned for what's coming next.